Tengku Ampuan Rahimah, Klang as the head till present. Today, she is also a supervisor to fellows trained for pediatric ophthalmology, supervisor for trainees in Masters of Ophthalmology, Masters in Emergency Medicine, and Masters in Family Medicine during their ophthalmology rotation in Hospital Tengku Ampuan Rahimah, Klang. She is also an honorary lecturer for undergraduate medical student for Management Science University, MSU Shah Alam, and also actively involved in teaching postgraduates and also an examiner for Masters in Ophthalmology, Masters in Optometry, and Post-Basic Trainees. Dr. Fazilawati is also a member of the Council of Ophthalmology Academy of Medicine Malaysia, an international member of the American Academy of Pediatric Ophthalmology and Strabismus, World Society of Pediatric Ophthalmology and Strabismus, and also a member of the International Pediatric Ophthalmology and Strabismus Council. Let's listen to her presentation. And Dr. Fazila, over to you.
Hello, Assalamualaikum, and good afternoon. Firstly, I'd like to thank the Dr. Isra as the chairman for his kind introduction. And of course, not forgetting, thank you very much to DKSH and also the Academy of Medicine and Malaysian Medical Association for supporting this multiple disciplinary conference 2021. Now, my topic for today is pediatric allergic conjunctivitis. It is a very common disease among children, especially. Now, firstly, I'd like to disclose that I have no financial interest or relationship to DKSH or other supporting companies. Now, what is conjunctivitis? It is inflammation of the conjunctiva. It is characterized by dilatation of the conjunctival vessels, resulting in hyperemia or redness, and edema of the conjunctiva, which is swelling, or can be chemosis if it's very bad. It is usually typically associated with discharge. So you will see redness here, all right, and then tearing, and also swelling. Now, conjunctivitis can be classified into four main categories, which are bacterial, viral, allergic, and miscellaneous, which is associated with systemic disease like Kawasaki disease, Sjogren syndrome. Now, the common bacteria involved is Staphylococcus species, Streptococcus, or in Haemophilus influenza. As for viral, 80% of acute conjunctivitis are usually associated with virus. And allergic consists of 70%, 70% of allergic conjunctivitis has association with allergic rhinitis. And as mentioned just now, as for miscellaneous, it can be due to a systemic disease. Now, how do you differentiate all these conjunctivitis? In bacterial conjunctivitis, in all conjunctivitis, first you have redness, you have swelling and tearing at times. Okay, how do you differentiate it? In bacteria, you have fast discharge, all right? You have pain. Okay, that's bacterial. How to differentiate it? Lid crusting can occur as well. As for viral, same thing, hyperemia, hyperemic conjunctivitis, a bit of swelling here, and also tearing, but watery discharge. Okay, and usually associated with upper respiratory tract infection symptoms. In allergic conjunctivitis, same thing, redness, swelling, tearing, but you must have itching, all right? So that differentiates. If you have itchiness, it is usually due to allergic component and can be associated with nasal congestion and sneezing, as in allergic rhinitis, or what sometimes they call it as rhinoconjunctivitis. Allergic conjunctivitis affect 30% of the general population, including adults and children. Now, I'm going to talk more on pediatric allergic conjunctivitis. For pediatric, for children, it is very important to recognize early and treat early, because if you don't treat early, then the child can have corneal scarring. And when there's corneal scarring, the vision will be affected, especially during the embryogenic age, which is 1 to 3 years old. Now, there are 6 main clinical forms of allergic eye disease. Acute allergic conjunctivitis, seasonal allergic conjunctivitis, perennial allergic conjunctivitis, vernal keratoconjunctivitis, and atopic keratoconjunctivitis with giant papillary conjunctivitis. I'm going to emphasize more on these 4 rather than the 2 because this is mainly in adults, right? 20 to 40 years old. Whereas this one, it can occur in children as well. Now, how does allergic conjunctivitis occur? So firstly, you have a central mast cell, and when there's antigen, which is the pollen or the allergen, combines with the immunoglobulin E, and it will degranulate the mast cell, and the mediators of prostaglandins, tryptase, and heparin will be released. Histamine will also be released, and this in turn will cause vasodilation, which is the redness of the conjunctiva, and there will be gaping of the endothelial and fluid leakage causing swelling. Okay, so in allergic conjunctivitis, the main culprit is actually the mast cell. So whatever we do, we have to control the mast cell. Okay. Now, what are the clinical features of the allergic conjunctivitis? In acute allergic conjunctivitis, occurs in children caused by allergen, swelling of the conjunctiva, hyperemia, and itching, as I've mentioned. Seasonal allergic conjunctivitis is usually in 10 to 40 years old. Seasonal allergens and usually occurs during like spring seasons. Yeah, it is seasonal. And then it is characterized by itchiness, burning, red eyes. Perennial allergic conjunctivitis is similar to seasonal. However, it lasts for more than 1 year. All right, it lasts for more than 1 year. Example is like house mites. Vernal keratoconjunctivitis, which is very important and quite difficult to treat because it is like a wax and wane kind of disease in the sense that it resolves and after that it recur again and then resolve again. You know, I mean, it's like that. Onset is usually in 10 years old, children, boys more than girls, usually occurs in warm, dry climate. It is characterized by thick ropey discharge with giant papillary, palpebral cobblestone papillae, and onostrantous dots at the limbus. And also you can get punctate erosion, punctate epithelial erosion, shield ulcers, and also can develop keratoconus. I'll explain to you further on vernal keratoconjunctivitis. I have some pictures to follow. And atopic is usually in 20 to 60 years old. Usually there's a background of atopic dermatitis, scaly crusty eyelids, papillae, and they can get cataract as well. For giant papillary conjunctivitis, it can occur at any age and usually in patients with contact lens. You know, they like to, I mean, they are contact lens wearers. Okay. Now, yeah, so this is example of the features in vernal keratoconjunctivitis. It is featured as there is a ropey discharge, you see here, and cobblestone papillae, and this is the discharge actually, and this is the trantous dots at the limbus, and punctate epithelial erosions. All these is very, these punctate epithelial erosions, if you just leave it like this, it can become scar, all right? It can become an ulcer, and as you know, when it's ulcerated, infection can occur and scarring and then poor vision, all right? So that's why it's very important to treat early, recognize early. Now, what are the therapeutic strategies? You have non-pharmacotherapy and also you have the pharmacotherapy. Non-pharmacotherapy is education first, right? No eye rubbing, even though I know it's difficult, but you have to tell the parents, the children, and avoid allergen. There's no point in treating when the allergen, the cause of the disease is not addressed. And of course, cold compresses. This is mainly for symptomatic relief. And artificial tears. Artificial tears is good in the sense to dilute the allergen and also to moisten the eye. Because in allergic conjunctivitis, the eye tend to be dry, all right? So the cornea will feel like some gritty sensation because of the dryness. So when you put artificial tears, you moisten the eye, therefore the eyelids can rub smoothly over the cornea. Example, as in your car wiper at the window shield, right? If there is sands, you feel the wiper won't wipe smoothly. So it's like the same concept, okay? And then other than that, the pharmacotherapy will be antihistamine eye drops, mast cell stabilizer eye drops, or combination of both, all right? And topical steroids is a very potent drug, but you can only use it in acute cases because it has side effects, complications like cataract, high intraocular pressure if you use it long term. And oral antihistamine, this is good as well in BKC and SAC, seasonal, to control the disease other than the topical. The example is like loratadine because it would cause drowsiness. Intranasal steroid spray, especially in rhinoconjunctivitis. Immunomodulators like topical cyclosporin A, we 2%, 1%, 0.5, and 0.05%, but the one commercially available is the 0.05%, which is Restasis. But it is mainly for dry eyes, actually. I usually use the 0.5% for vernal keratoconjunctivitis. Just a minute. I lost my screen. Okay, sorry for the technical glitch just now. So we are now back in business. Topical cyclosporin, 0.5%. It's a dilute by the pharmacy. Our own pharmacy diluted. Tacrolimus, 0.02% ointment is good as well, but I've got no experience in this actually. We have it only in Hospital Sungai Buloh because that is the corneal center. And of course, if there's blepharitis and dry eyes, you have to treat it as well. Pharmacotherapy, as I've mentioned, topical antihistamine, antizolin, imidine. Long-term use is not advised because you can get rebound hyperemia when you stop. Systemic antihistamine, as I've mentioned, in allergic keratoconjunctivitis and vernal keratoconjunctivitis. Mast cell stabilizer, is like sodium chromoglycate, it's like Opticrom. It is good because it decreases in degranulation of mast cells in response to an antigen, but it may take a few days before the effect is observed. So combination with other drops is needed for immediate symptomatic relief. Therefore, we have the dual acting agents, example like the olopatadine, nadocromil, ketotifen. So dual-acting agents, which is a combo of antihistamine and mast cell stabilizer, is the first-line drug of chronic conjunctivitis in many. Okay, and it also has anti-inflammatory effects such as inhibition of cytokine release by the mast cell. And another type is the non-steroidal anti-inflammatory drugs, which is the ketorolac. It is good also to relieve ocular itching, but actually it is less efficient compared to antihistamine. And steroids. Topical steroids are extremely potent. It's very good. It's very fast. Yeah, you need to use it, yes, short pulses during flare-ups, but you have to be very careful You cannot use it judiciously because it can have complications like cataract, increased intraocular pressure, and it can increase the risk of viral or fungal infection. So you have to be careful, because I've seen patients on topical steroids for 3 years, and now came to me, already has cataract. Okay. Now, immunomodulators like topical cyclosporin A is effective too in allergic keratoconjunctivitis and vernal keratoconjunctivitis. The 0.5%, the 0.05% doesn't really work. It is mainly for dry eyes. It's the 0.5%, but that you have to self-dilute because we don't have it commercially, right? Okay, this is the table, right? The commonly used topical medication in allergic conjunctivitis, as I've mentioned. First line is olopatadine, Patanol 2 times daily, or Patadine once daily. Now, how does all this medication work? For decongestant, so what it does is, it just stops the vasodilation, okay? Prevents vasodilation. So there's no redness, there's no swelling, because there's no leakage of fluid. However, the mast cell is still degranulated, the histamine is still released, the other mediators is also released. All right. And when you stop, it can have a rebound vasodilatation. What about topical antihistamine? Okay, you just suppress the histamine and prevents the vasodilation and the swelling. However, the mast cell is still degranulated because the other mediators is still being released. Okay. So only relief itching and erythema, but no effect on the inflammatory mediators. So what about mast cell stabilizer? Mast cell stabilizer, it prevents degranulation of the mast cell. All right. When it prevents degranulation, it prevents release of histamine and the other mediators, and prevents itching, all right? And there's no swelling and redness. However, it takes quite a while for it to take effect, a few days, okay? So it is good in prophylactic treatment. What about the dual-acting antihistamine and mast cell stabilizer, the combo, all right? So you have both. You prevent the degranulation of the mast cell, and then you suppress the histamine, all right? You prevent release of histamine, therefore, indirectly, no vasodilation, no swelling, and no itchiness, okay? So, it gives an immediate relief. So, antihistamine and mast cell stabilizer, the combo, is considered first-line treatment in allergic conjunctivitis. And and one of it that we have here is Patadine, olopatadine 0.1% of, no, actually Patanol is 0.1 and Patadine is 0.2%. Now, how do you choose an eye drop for allergic conjunctivitis? You must think about efficacy, long lasting, it will last long, and compliance, yeah, that means the patient will use it, all right, and safety and tolerability. So for efficacy, I mean, if you compare placebo and olopatadine 0.2%, it acts fast. There's no itching within 3 minutes. At 3 minutes, 63 patients suppress itchiness, okay? And in 7 minutes, 65. Okay, this is based on Kaba et al. In clinical optometry in 2011. Okay, so in for Vogelson in allergy and asthma, the mean itching score is also very fast. In olopatadine, right, within 24 hours, the itching score is less than 1. All right, in 3 minutes, it is less than 1. In 20 minutes after time instillation, the itching score is less than 0.5, so it's very fast actually. All right. And there is significant improvement in the quality of life with olopatadine. Like for example, in this, the patient cannot sleep, and after olopatadine, it can sleep well. They can do activities, and eye symptoms is less. From very negative eye symptoms, now it's positive. Okay. It is long lasting because it can last the reduction of redness and itchiness for about months. Yeah. If you compare olopatadine and the placebo, okay, it can last until about 70 days. It suppresses the itching score, suppress the itchiness, mean itching frequency score is less, all right? And then the redness is also less, okay? And the severity is also less, and also redness severity is less in olopatadine. And it lasts for less than 3 months, about 70 days, about 3 months, yeah? Around that. And compliance. It is a once daily dosing for PET a day, and retinol is twice a day. So it is very easy to follow, right? You won't forget. And then from this, even with olopatadine 0.1% with a BD dose, the mean itching score is less than 1. Okay, with 0 to 1 is mild, right? 4 is severe. It is statistically significant. But then between olopatadine 0.1% and 0.2%, there's not much difference. Okay, both are as good. All right. In some papers, there's one paper from Japan, they even use olopatadine 0.1% as in QID 4 times a day with no adverse events. All right, so you can. All right, safety and tolerability. There's no adverse events, just some ocular discomfort, a bit dryness, but there's nothing serious, all right? It is well tolerated in children 3 years old and above. Okay, just ocular discomfort, a bit of hyperemia, and that's it. Okay. Better satisfaction after 1 month, 87.6% feels that the symptoms is much less. They're more satisfied. Now, other than pharmacotherapy and non-pharmacotherapy, you have the surgical treatment. As in this case, vernal keratoconjunctivitis. You can also give supratarsal injection of a mixture of triamcinolone, 20 milligram or 0.5 ml, and dexamethasone, 2 milligram or 0.5 ml. It usually improves in 1 to 5 days. The shield ulcers and giant papillae resolve within 2 to 3 weeks. But this is not a one-off treatment. Sometimes you need to repeat after 4 to 6 months. VKC is a wax and wane disease. It resolves, it occurs, it recurs again, and resolves and recurs again. But usually the gap between the first supratarsal and the second is a few months. Usually it's more than 6 months actually. I have one patient that I only gave once and that's it. But there are patients that I have to repeat after 4 months, after 6 months. All right? Okay, this is the picture after the supratarsal injection. If you notice, there will be, the papillae is resolved. Okay, like with the supratarsal injection, it already resolved. Debridement of a shield ulcer, yes, I've done that and it works. Yeah, after debridement, it just healed up. Amniotic membrane transplantation. So far, I've never had to do amniotic membrane transplantation. So to conclude, extraocular disease in children can be difficult to manage. Differential diagnoses are varied, so you have to know for which and which. As mentioned, you must know, right? The characteristics of bacterial, pus discharge, pain, viral, watery, okay? Allergic, itchy, must have itchiness. Okay, vernal keratoconjunctivitis is usually that cobblestone papillae. Okay, so you must know, and then you must cater the treatment that is tailored for it. And of course, you have to examine visual acuity, ocular surface, the lids, and also microbial investigation if needed. For uncooperative children, you must do an examination and the anesthesia to really see what is, what type of allergic conjunctivitis it is. With that, I thank you.
Thanks to Dr. Fazila. We are very pleased with your presentation just now. And now let's move on to Q&A session. Okay, we go to the first question here. Which eye drop is safe for children?
Actually, it is quite safe, but depends on the severity of the disease and depends on the age of the child. If it's just conjunctivitis, it's okay to just give antibiotics. I mean, like chloramphenicol, but of course, everything has to be, you have to monitor. You give them for a week and then you have to call them and see what, how's the progress like. So, and then if, another thing is you can use preservative-free artificial tears to start off if you have children with conjunctivitis.
Okay. Second question. Do you routinely order an allergen test like blood or skin prick test for any patient with any of these atopy conjunctivitis or BKC?
I wouldn't do routinely order an allergen test, but of course, if your hospital has the means to do it, it's okay to go ahead. But actually, it won't really change my management because it depends on how severe is the disease. If I need to use steroid, I would still use, other than the antihistamine and mast cell inhibitors. Yeah.
All right. Talking about the steroid, the next question is, do you use dextrin, which is dexamethasone and neomycin for allergic or bacterial conjunctivitis?
I've got no experience actually with dextracin, but I do use dexamethasone for conjunctivitis, but usually with a 2 separate bottles, not a combo. Like supposing in a dexamethasone example, Mexidex, the one that we have, and then with chloramphenicol or cefuroxime, like siloxane, for allergic or bacterial conjunctivitis. But of course, for dexamethasone, I have to monitor properly because, example, if you start off with 4 times a day for a week, you need to taper it 3 times, 2 times, and then every other day, and then you see from there if needed. But if it's just 2 weeks for 4 times, and then it has resolved, I would just stop like that because I do not want to be, the side effects, as we know, of steroid is very bad. They can have cataract, high intraocular pressure, secondary glaucoma and all that. So we have to be very careful. Neomycin is okay to give the children. There's nothing wrong with it.
Okay, continuation with same question. Is it safe to prescribe steroid or antibiotic eye drops in children for mild cases of conjunctivitis?
For mild cases, I wouldn't give steroids. I would just give antibiotics. And then I'll call the patient in about 1-2 weeks, and then I'll see how it goes. If it's become severe, then I may think of steroid. But if I do use steroid, I will take the mild steroid, not the proper one, like maybe fluoromethalon or lotexamax and all that. Yeah.
Okay. The next question, can optichrome be used in children less than 3-year-old?
Optichrome, actually, based on the manufacturer's suggestion, it can only be used for children more than 6 years old.
Okay.
But not below that, yeah.
All right. There's a question that, may I know your experience with subtarsal injection of triamcinolone in severe PIDS cases?
Okay, I've started using supratarsal injection for triamcinolone since 2009, when after I got back from Toronto. So I have a vast experience, and so far, I do not have any secondary glaucoma. But of course, I don't give it regularly. I give it, and then if it still recur again, maybe I wait 4 to 6 months before I give another shot of triamcinolone. In the meantime, it'll be just eye drops.
Okay. Then Dr. Gayatri asked about duration of treatment with olapatadine.
Well, you can, as in my presentation just now, you can give it for about 70 days, which is about 2 months plus, and then you see from there. I mean, if it's needed, then you can add. I mean, you can continue, but of course, you have to be, you know, once the symptoms resolve and the signs also resolve, then you should stop. It cannot be a lifelong treatment.
Okay. Okay. The next question: from what age is steroid eye drops recommended for pediatric, and do you recommend for eye specialists to prescribe it in view of its side effects?
Actually, I don't really have a cut point for steroid eye drops. I mean, like what age and all that. It depends on the severity of the disease. I mean, sometimes in pseudomembrane conjunctivitis, for example, which is very bad, I use steroid eye drops, but of course not regularly. Maybe it's an OD dose, you know, like example ointment next to at night, and that's it. But I don't use it regularly. But of course, for children, you have to be very careful, because we do not want side effects. I mean, it is really devastating, you know, if they suddenly get a secondary glaucoma or cataract. And there's also a risk of infection with bacteria, fungal, if you use the steroid for long term.
Right. Okay.
Do I recommend for eye specialists to prescribe it? And you say, yeah, it's okay, because eye specialists, they are trained to know when to stop, how to taper, you know, and when not to, when to start. It's okay.
Okay. So the following question: so what to give in children less than 3 years old?
You can give artificial tears then, you know, just artificial tears. If they have conjunctivitis with antibiotic. Antibiotic alone is fine. Antibiotic and artificial tears. And then you see from there. If it's severe, sometimes I mean, I think it's best that you refer to the eye specialist, because they may give steroid, you know, when it's really severe, like in pseudomembrane and all that. But of course, it has to be very, very careful. You cannot just like simply give, you know, like 3-4 times a day for a month and all that. Yeah.
Okay. There's one question: can we give chloramphenicol eye drop to neonates?
Okay. Actually, it is not recommended from the manufacturers. I mean, they have these indications and contraindications. It's not really, but I know that chloramphenicol is easily available actually. Frankly, I have used it before, but I don't use it like regularly. You know, maybe after a week I see again and I stop. Sometimes I just use ointment, fusidelmic, like TDS, the ointment. I think it is quite all right, because as you know, in children, especially neonates, sometimes they won't really allow you to put eye drops, so it is good to give the ointment type, because it will stay better.
Yeah. There's one question here: any advice on the efficacy of lutein and zeaxanthin in patients with allergic conjunctivitis?
Lutein.
Yeah, lutein and zeaxanthin. Any efficacy in patients with allergic conjunctivitis?
Lutein and zeaxanthin.
Yeah.
To be frank with you, I've never used lutein and zeaxanthin in patients with allergic conjunctivitis. I don't have experience in that. Yeah. So yeah, I have to read further about it, because I'm not sure.
All right. Any role of prophylaxis eye drop for recurrent episodes of, I presume, allergic conjunctivitis?
No, not really. I mean, if the conjunctivitis has already resolved, I just off everything. I don't, you know, I don't give prophylactic antibiotic or anything like that.
Yeah. Okay, I'm going to combine Dr. Besima and Dr. Zaidatul question. For a GP, what are the warning signs or red flags that warrant an urgent referral to an ophthalmologist or PITS case with conjunctivitis?
Okay, the red flag is if the conjunctivitis is in a newborn, all right, if it's less than 30 days, a baby just born like 3 days or less than 1 month, that is a red flag. Why? Because we don't want you to miss a neonatal conjunctivitis, which can be trachomatis, all right? Because if that happens, we need to refer the ophthalmologist for intravenous penicillin, okay, herpes and all that. We're afraid of that because if you don't refer, they can get bacteremia at home, and then patient can just succumb to death.
Okay, how long duration can we prescribe Pediatric eye drop for allergic conjunctivitis?
You can give for a month or 2 months if it's okay. It's quite safe. Yeah.
Okay, that's a question. Is all conjunctivitis required to be treated as in isolation case?
Allergic conjunctivitis, depends. It is actually yes, but I think the SAC and PAC, VKC is not really contagious. But if it's the conjunctivitis that you always get, which is very tearing and sticky and red, you have to take it as contagious. So the child cannot be using the same towel as the brothers or the parents, and then cannot cannot share the same pillow because it is infective. Yeah.
Okay, the next question. How to decide whether to start Pediatric or Optichrome?
How to decide? Well, it depends on what you have. Yeah, Optichrome is a mast cell inhibitor. It doesn't work as fast as Pediatric. Why? Because Pediatric has antihistamine. If you don't have Pediatric, what you can do, you use 2 types of drops, meaning that you use antihistamine drops and also Optichrome, meaning you have antihistamine and mast cell inhibitor. Mast cell inhibitor, the effect will take a few days actually before you see the symptoms resolve. Pediatric, because of the antihistamine, you can immediately see the eyes become white actually, because of the vasoconstriction of the blood vessels.
Okay, let's go to the next question. Is Neodeca antibiotic eye drops advisable for mild eye infection, or shall we go on oral antibiotic or oral steroid?
For mild eye infection, I don't usually use steroid eye drops. I just use antibiotic. So that means if you have Neodeca, that means you just use the eye drops with just neomycin without the Dexa. Okay. For first line, I won't straight away start a steroid. Why? Because you never know. It's probably not allergic conjunctivitis. It's probably herpes simplex. If it's herpes and it's virus, herpes virus, then it will worsen when you put steroid. So that's why you have to be very careful. And if you really give steroid, you have to call the patient early, say in about 3 days time, not 1 week, because we don't know. All right.
Okay, this is regarding your supratarsal injection. In a patient who presented with more of limbitis instead of giant papillae, is it possible to give supratarsal injection of dexamethasone or triamcinolone?
If it's just limbitis, I won't give supratarsal injection, Dexa and triamcinolone. It has to be very severe, meaning limbitis, giant papillae, and then symptomatically sticky and vision drop and all that. If it's just limbitis, I would just give topical steroids with antibiotics.
Okay. Okay, Dr. Ngai Yuan Jing has two questions here. How long can we use steroid eye drops? That is the first question. And second question is, can Nefcon A be used in children 2 years and above?
All right. How long can we use steroid eye drops? Actually, if you want, you can use steroid eye drops without tapering actually for 2 weeks. After 2 weeks, then you need to off or you need to taper. But after 2 weeks, I mean, if it's already resolved, then just off it. If it's still not resolving, then you can reduce the frequency. Say maybe you start off with 4 times, you reduce to like 4 times a week and 4 times per day for a week, and after that 3 times TDS, and after that BD, and then every other day, and you watch from there. You have to taper. Nefcon A, based on the manufacturer's suggestion, it can only be used for 12 years above actually. Okay,
Right.
but if you really need to use, what you can do is call them back early. Don't like, call back 2 weeks or call back 1 month. I think, yeah, because it has, I mean, the indication, it is actually not for children 2 years and above. It's for 12 and above.
Okay. For a long term.
Depends on the age of the child. All right, if it's above 6, you can put on the stasis, and you can use it for long term. Long term, as in, let's say maybe 3 months, 6 months. But of course, you have to see again. I mean, you have to revisit it. Revisit. I mean, you have to taper again. I wouldn't say long term as in whole life. Okay, but it's okay if you want to use it for 3 months, 4 months, 6 months, it's fine. Then after that, you have to see again whether you really need to continue or not.
Okay. The next question is regarding antibiotic option or have less antibiotic resistance incidents.
Okay, my experience is mainly on with neomycin actually. I don't usually use polymycin.
Okay. All right. Let me see. Okay. Do we combine Patanol or Pataday together with Optichrome at the same time during acute cases and start to off Patanol or Pataday later on while continuing the Optichrome?
Actually, no, because actually in Patanol and Pataday, they already have a mast cell inhibitor. Because as I mentioned in my presentation just now, Patanol Pataday is a combo of antihistamine and mast cell inhibitor. So you'll be adding double mast cell inhibitor if you give Patanol Pataday and Optichrome. But during the acute cases, if you can off the Patanol Pataday and maintain it with Optichrome, yes. And perhaps you add in artificial tears, because in allergic conjunctivitis, they tend to have dry eyes. So as I mentioned in my talk as well, the artificial tears is good in diluting the allergen and also to moisten the eye.
Okay. The next question from Dr. Ng Soon Peng. Loteprednol has apparently a better safety profile. Any comments for use in pediatric patients?
It is a weak steroid. Okay, so I do recommend it for pediatric actually. It's Lotemax, if I'm not mistaken, the patent name. Yeah.
Okay, do you recommend antihistamine drop for perennial conjunctivitis as prophylaxis?
Perennial, yeah.
Okay.
Can.
All right. Okay. I think you have answered these questions. Okay. From Lo Su An. Since the culprit is the mast cell, should we just continue olapatadine as a prophylaxis for long term, especially in the cases of recurrence? And if so, for how long?
Yes, you can. You can use Pataday for Patanol. I mean the combo for long term. You can use it as long as 3 months, and after that you see again. If it's needed, you can continue actually.
Okay.
Yeah, I think it's okay for 6 months as well. It's not a problem.
All right. Next question. In G6PD deficiency, neonates, what is the best antibiotic eye drop to be given in order to treat the bacterial infection?
G6PD, I think depends on what the patient is allergic to, right? I mean, I think it's okay to give any antibiotics. Maybe not chloramphenicol, I think. I think if you want cefuroxime will be better, like siloxane or Vigamox and all that. Yeah.
Alright. Okay. There's a question from Dr. Chong Hui Ting. Does a patient always request from doctor for artificial tears and chloramphenicol eye ointment and use them for a long time, more than a month, despite being counseled? Any suggestion for this patient?
Okay. For long term, it's okay to use the artificial tears. That's okay. But I think chloramphenicol eye ointment, I'm not sure. I don't think so. You can use it for every day for long term. And I don't see the reason why this patient wants it. Is it because he has allergic conjunctivitis, and then the eyes are sticky every morning when he wants to open the eye? Then you can just continue. I mean, you can just use the ointment type of artificial tears like Gentil or Tears Naturelle. Maybe that's the reason why he wants the eye ointment. Yeah, other than the artificial tears, because probably the eyes are sticky when he wakes up.
Okay, the next
so
question.
So you can use Gentil ointment.
Ointment Gentil. Okay. Regarding CMC eye drop, can it cause allergic reaction?
It can actually. Yeah, it can, because I've seen before, and if it happens, just off it. So far, not adverse events. Just like, the patient feel more itchy and more red. That's all.
Okay. The next question. What is the eye drop to be used for frequent eye blinking in children?
Okay, eye blinking in children. I've seen a lot of this, in my practice. Sometimes it's just habitual, but sometimes it's really because it's allergic. All right. So if that happens, sometimes what I do, and sometimes it's also dry eyes, but frankly, dry eyes seldom happen in children. Okay. If it happens, then what you do is I use Petanol for this frequent eye blinking, and I add artificial tears as well. Okay, and then another thing, you have to find out about the vision of that patient. Sometimes they have poor vision or they have astigmatism. So when they blink, the vision is clearer. So you have to refer them to the optometrist as well to make sure, is it not because of vision?
Yeah. Okay, next question. Antibiotic eye drop can be given to allergic conjunctivitis too?
Oh, yes, definitely. Yeah. I mean, in fact, that's first line.
Okay.
Antibiotic first. Yeah.
Okay, Dr. Lim Ying Hong want to ask if required for systemic antihistamine, any recommended oral antihistamine that works best for reducing eye itchiness and edema?
I like to use Zantac. Okay, because Zantac is not drowsy, and then it's quite fast actually. Yeah. Okay. Most of the time I use Zantac. I prefer that.
Okay, the next question comes from Dr. Lim Pizin. I think maybe this is one of his patient. In a case of recurrent conjunctivitis, almost one attack every month, and what should be investigated and counseled to patients who always come for his monthly neodeca?
I think in cases like this, you really need to do allergen test, the skin prick test and all that, to find out what is the cause of the allergy. Okay, but to be frank with you, sometimes I have patients who have gone through all this. They know they're allergen as well, but somehow they avoid it, but sometimes it still happens. I can't really tell. But you have to counsel him. He cannot take monthly neodeca. He may end up cataract later on and secondary glaucoma. I mean, because I know why he comes for this monthly neodeca, because as I've mentioned in my talk, the steroid is a very potent drug. It's very fast. And then the eyes suddenly become white. So they really like it, but it is not without side effects. You can get glaucoma, intraocular pressure high, you can get early cataract, and you'll be prone to infection like virus, fungal, and then which can lead to ulcer. So you have to counsel him, and you have to put your foot down, not giving him neodeca every month. Okay.
Okay, one of our participants would like to know, when exactly would you decide to start cyclosporin for allergic conjunctivitis?
All right. Actually, for cyclosporin for allergic conjunctivitis, I would start, it is usually after in this type of patients, usually they feel that once they stop the steroids, the conjunctivitis occur again. So this is the type of patient that is like very dependent on steroid eye drops. This is the type of patient that I will try off cyclosporin. I would start with cyclosporin, but it has to be cyclosporin A, 0.5% only, then it works. If 0.05, you can try, but sometimes it doesn't work. It has to be a higher concentration actually. And that can only get in the pharmacy. You have to, self-dilute in the pharmacy. It's a compound medication diluted in the pharmacy. 0.05 is commercially available. Like in our hospital, we can prescribe and the pharmacy will do it for us.
Okay, the next question from Dr. Ramanathan. Can lidocaine eye drop be routinely used once during a clinic visit to ease the symptoms immediately? Lidocaine eye drops.
Yeah, okay. Lidocaine eye drops, it is actually to numb the eye so that the patient won't feel so much pain. Well, I wouldn't say, you cannot prescribe lidocaine. It is not correct. But of course, if the patient comes to you and it's difficult to examine him because he has pain, it is okay to give one drop just so that you can examine the eye and that's it. But you cannot give him as in, to ease the pain. Yeah, it is not the right method.
All right, the next question from Dr. Brian. If we suspect patient is having viral conjunctivitis, do we need to treat with antiviral eye drops or cover with antibiotic eye drop? Or is it safe to treat with artificial tears only?
Okay, viral conjunctivitis eye drop. Viral conjunctivitis, you just cover with antibiotic eye drops and artificial tears only. The antiviral eye drops, actually, the one that we have, it's not really eye drop. It's it is ointment. Yeah, ointment that is mainly for herpes virus simplex, or herpes zoster, ophthalmicus. But that is more actually even without topical, without eye drops, without ointment, just with medication alone, oral medication, yeah, usually automatically the eye will also resolve.
Okay.
Even with eye drop, even though with oral.
Okay, time passed so fast. Okay, we only can take one more question, Dr. Fazila. All right. Okay, I have to choose. Okay. Painful allergic conjunctivitis, any rule for NSAID eye drops?
Yes, you can. If you notice my presentation, there's ketorolac. Ketorolac is NSAID. You can use for allergic conjunctivitis as well.
Okay. Do you have any take-home message for our participant for today's session, Dr. Fazila, before we end up our session?
Okay. Firstly, you have to treat early, recognize early the conjunctivitis, and you must know whether you must know how to classify bacterial, viral, allergic, BKC. And second is actually steroids. I really hope that you don't use the steroid judiciously. I mean, you have to use it. You have to be careful in using it, not just simply. And of course, if you are not sure, and I mean, if you've been treating them for many months and nothing happens, yes, feel free to refer to us. Okay.
Okay, thank you very much, Dr. Fazila, and thanks to you, the audience. We hope you gain a lot of insight from this session. And our next session is lessen the pressure to reduce the intraocular pressure, which will start at 2:10 p.m. Do stay tuned if you are interested. Have a great day ahead, and goodbye.